Okay. Good afternoon, everyone. Quickly, I'll go into the topic algorithm for managing complex primary TKR. So, which TKR is complex? For one surgeon, it might be a simple, one surgeon, it might be a complex. So, we don't know exactly which is a complex TKR or a primary TKR. But I'm trying to sort it out in this order. A severe varus, a severe valgus, bone loss in a primary situation also comes under a complex primary, and extraarticular deformities all are. But I'm not going to go into the exact technique, but I'll just take you through few cases and see if that covers the most of the important aspects. 68-year-old female, severe OA, and you know that it is a very much badly damaged subluxed knee. It looks very bad, so it comes under a complex. So my algorithm here is always to take a stress view. Whether it is correcting or not correcting, make it as a habit. Stress view, both sides, varus valgus stress view, and this is the post-operative X-ray of both sides. A complex situation looks and turns out to be a primary knee replacement surgery. So what is there? It is managed by regular bone cuts and proper balancing and component placement. So see here the point I didn't make mention about the soft tissue. It is just needs a balancing between cuts and also the component placements. It will solve the issue. So how to do that, we are not going to go in detail, but the most important thing is the correct placement of the component with balancing. So again, 73-year-old female, osteoporotic with some amount of bone loss. Again, make the cuts very simple, minimal, and then go ahead and do the procedure whenever needed. Do this reduction osteotomy. Most of the time everything falls in place. So that is my algorithm here. Again, not much of any big soft tissue releases. Here the bone cuts, placement, and the reduction osteotomy. So by reduction osteotomy, this is how the post-operative X-ray. Severe, this comes to the next level. Severe varus, patient is walking like this. Definitely it needs additional some sort of screws and stems, definitely. Again, you look at the lateral view, see how much of slope and the bone loss is there in the lateral view. So you know whether the bone loss is in the anterior or in the posterior aspect, and then you plan accordingly. Then the stress view, you take the stress view, again both sides. Alignment view, skyline also should be the mandatory in your protocol. So this is the case where you can see posteromedially how much of sloping the bone loss is there. This is how the bone loss is there. So you have to manage the bone loss. Yes, it needs a stem augmentation because the bone loss is vertical, then screw augmentation. Try to use the smaller size tibial tray so that you can do a lateralization and a reduction osteotomy. So initial cut, make it small, then whenever needed, go back and do more cut, because the more cut you take, more bone you take in the initial period, then it becomes very difficult to balance it. So that is my protocol and algorithm in these kind of severe complex cases. So this is the post-operative X-ray of this patient, and this is the post-operative walking video. So then comes the rheumatoid with the valgus deformity, and if you look at the X-ray quickly, you will see that it is very bad and it is looks very complex, osteoporotic. We might need a hinge, all those things. But actually, if you see this patient, even though she is osteoporotic, how to proceed? Preoperative, what is that? Again, the stress view. See, the stress view shows not much of soft tissue problem, it is the bony problem. There is a bone loss, central defect. So that is how you assess the patient by taking appropriate X-rays. Then you know that it is not that complex. It is reasonably a straightforward procedure. See the defect here? It's almost like a central defect on the lateral side. So here you need to just take the correct bone cuts, make the alignment correct, get the rotation correct, and then after that you augment that bone defect, bone loss with screws and then cement, and then I prepare that way. And then this is what I didn't even use a stem here because of the central defect. So here only the screw augmentation was done. So this is the post-operative X-ray of both the sides, right and left side. So here comes an obese patient, history of trauma to right knee, 18 years back, conservatively treated. See here is looks a stiff knee, so much of osteophytes superiorly. So proper X-ray, and again the stress view, only this much of correction. Again there is a bone loss. So here how I manage. So the moment I opened this much of osteophytes, the moment you remove all these loose bodies and osteophytes, that itself is going to decompress the whole joint. So you have to keep that in mind. Once you remove the synovium, and then this is the bone loss. posteromedially, vertical. Once you do the reduction osteotomy and it becomes smaller and smaller. So no need to be scary enough in the initial stage, but have a very gauged approach so that you are not taking too much of bone. This is the secondary tibial cut, and then this is how the defect has become smaller, and then I augmented that with the screw, and here I have used a short cemented stem and also resurfaced the patella. And here the point here is I have lateralized the tibial tray so that I can use a small tray and I can do a reduction osteotomy, avoid the defect, a bigger defect, so that the defect becomes smaller. And this is what it is. Immediate post-operative X-ray after 3 months, patient walking, and recently he came back 3 years post-operative, patient is doing well. So here the reason for the stem, because of the defect, obesity, all those things made me to use a shorter cemented stem. Nowadays I use short cemented stems for these kind of bone defects. I don't use a long uncemented stems. Again, one more example, severe varus, same management, bone graft or stem. I use in this only the screw augmentation with the tibial tray. So here comes a obese patient. Again, this comes nowadays obesity. We see a lot of patients severely BMI 46. Whether to do reduce the weight and then do surgery? No, that is not possible in our part of the world. So here again, see the obesity, this patient. So this is a very classic case where you should think of augmenting it with the cement, particularly if the bone, there is a minimal bone loss with the osteoporosis. So again, I have done that short cemented stem with the minimal thickness of the insert. This is the post-operative walking of the patient. Again, right side also was done recently with the stem augmentation. Next example, the topic was clinical radiological. So here if you look at only the radiology, you can see that it is a simple varus deformity. But once you examine the patient, I always make the patients walk and I examine them, look at them, see how they are walking. That will show you a lot of information. Very important. Particularly these kind of complex situations. See the hyperextension in this patient. So in this case, I used a distal augment. I reduced the bone cuts. In spite of that, I had to use a distal augment in the femoral side to bring down the femoral component to get away, to manage that hyperextension. So this is the post-operative X-ray showing. So if you look at the insert size, it is the smallest insert. That is the most important thing. Here I have not used more than 8 here. So this is the smallest insert. I've used augments, and because I'm using a bigger augment, I've used a stem, short cemented stem in the femoral component. So that is my algorithm here. Rheumatoid stiff knee, very, very stiff knees. I manage by tibial tubercle osteotomy. So this is how the tibial tubercle osteotomy is done. Once the tibial tubercle osteotomy is done, I do the procedure and then I don't use any metal. I use only this 5-0 Ethibond to suture it back, and this is the 3 years post-operative X-ray. So tibial tubercle osteotomy, yes, not in all cases it is not needed, but these kind of very stiff knees, I use this and it gives me good results. Extra-articular deformities, yes, we can have an entire separate session on this, but just before robotics, I use navigation for this extra-articular deformities. Again, this case was done by navigation. See that deformity, I use the Cora angle. See how much of varus angulation. This is more than 20 degrees. And if it is there, then it is difficult to correct it intra-articularly. It is not advisable also, because to balance it, it becomes very difficult. So I will suggest to use some sort of technology. So here again, I have used, since it is more than 20 degrees, I have used a navigation, and these are the navigational slides, planning, verification, and this is the post-operative X-ray. So no need of any osteotomy correction, no need of any plate augmentation. Yes, majority of the times you can get away with intra-articular correction, but you have technology, please use it, that helps you. This comes under not under a complex primary, but an implant is there, 73-year-old female, osteoporotic. So what to do, whether to do a 2-stage, single stage, removal of implant, do a TKR, bone loss, so many things are there. So in this case, I used a robot here. So if you have access to technology, please utilize that, and it saves you a lot of, not only the cost, but also 2 procedures, so many comorbid issues. So this is what the post-operative X-ray, without removing the implants, particularly on the femoral side, it's so advantageous. So to summarize, Always I use secondary bone cuts in complex cases, downsizing the tibial tray, lateralization, screw augmentation, and if larger defects, stem augmentation. Do not hesitate to use technology. So in each case, it should be individualized. Don't fix it in everything your algorithm. But certain habits in radiology, clinically examination, always follow certain set protocol so that it becomes a habit not only for you, for your entire team. Thank you.